Welcome, welcome everyone to our International PA Organization and Comparable Organization meeting. Thank you everybody for being here. And as you all know, I'm Mary Shosark, and so I'm AAPA, Lisa's unofficial global ambassador. Who is basically here to try to help host this meeting in preparation in advance of our AAPA conference that is actually coming up. So I'll have Lisa start off. So we were going to have the 4 orgs start with some of the updates and then move into our international orgs. And we're going to also let Peter speak early because he has to leave. So we'll sway from alphabetical order, but we're going to move in alphabetical country order. So Lisa, take it away.
Sure. Thanks so much, everyone, for joining us today. We're very excited to see you again and hoping that some of you can make it to the conference in Houston, Texas, in 2 weeks, I think, 2.5 weeks. So just real quick, some updates. You may be aware that in the United States, we have finally passed the compact licensure. We have 10 states that have passed it, 7 were required. And what this means for us is that a PA is able to eventually, in about a 1.5 years or so, will be able to register and license in one state and be able to operate in multiple states. And this is really important for telemedicine. So I think it's an advance that we've made over the last 2 or 3 years. We've been trying for this and finally got it. The other big news is we finally, as you know, have been working on title change. So physician assistant to physician associate. And we have our first state that has adopted title change, Oregon, which will take place effective later this summer. And we're excited about that. And hopefully next year, we'll see many more states follow suit. So a lot of good things going on here in the United States. The Academy is doing very well, got a lot of things going on, and hoping that you all take advantage of the opportunities whenever you get a chance. So welcome, everyone, and thank you for being here today. Thanks, Mary.
Of course, thank you. And thanks for those updates. And just another update that Lisa and I have met with a few other people with the International Labor Organization. And I know a lot of us are very passionate about some kind of different name or different, but we want to try to, we've been working with them to give everybody's titles so that everyone is recognized. And then maybe we have this kind of global name. Scott will talk a little bit about that in just a few minutes. I'm going to have Scott go next because nobody else is from the 4 orgs, and then Peter will have you go afterwards. Scott, you're on mute, and we'll have the real Scott Smalley speak.
Yes, thank you so much, Mary. My name is Scott Smalley. It's great to be with everyone. I'm currently the president of IAPAE, the International Academy of Physician Associate Educators. And I've given my link to others in the WhatsApp group, so people might join as Scott Smalley, but here is the real Scott Smalley, IAPAE in the background. And for many of you know, IAPA, as we like to call ourselves, is a group of global PA educators and PA analog and comparable educators. We started in 2007, and we've been growing year to year. We always hold an annual conference, and we're excited this year. The conference will be in Lynchburg, Virginia, and we're hosting with the Master PA program at Lynchburg, and along with the Doctor of Medical Science program run by folks there. And our organizing committee is run by Tom Coletti, also a fellow educator with this group. So that date is the 1st to the 4th of October. And I really hope everyone will be able to join us. And we'll have international delegates, we'll have regional delegates, we'll be sharing about international education and scientific activities. One of the main projects that IUPA has been working on is to map the curriculums of all of our PA and analogs around the world. So we've done quite a bit of good research to show 68 countries around the world that have our PA program, or what we're starting to call clinical practitioner. We might all fall under this global term, clinical practitioner. Mary's showing just a bit of the loop right now. This is an online software where we can upload the curriculum and map the curriculum to the WHO Global Competencies Framework. And we can, for the first time, get real empirical evidence of what is taught in different countries and what could be our minimum skills that we teach, our minimum content we teach, and our minimum competency standards. We may be able to then propose international competencies for us. And that would just provide more evidence and more support for WHO, for ILO, as we go forward. So we encourage educators to join our loop. We have a monthly meeting. It's the third Friday of the month. If you're interested, please don't hesitate to email myself or Mary. We have about 8 to 10 active educators every month, and we have up to 40 countries we've identified for curriculums now. I'm also going to put in the chat our poster for the conference. So I really do hope that others can be interested for submitting an abstract, and you can share your work and research that you're doing around the world. Thanks for the time, Mary.
Excellent. Thank you for those updates, and thank you. And anyone who wants to join Loop, please do feel free to reach out to Scott or myself. It's very exciting to finally have this platform up, thanks to Olaf Allers, and getting these everything mapped to the competencies. Our next speaker, Peter, we're going to go in country order after we start with Peter. So Peter, thank you so much from Germany.
Thank you, Mary. Thank you very much, Mary, and thank you for your understanding. I hate these parallel conferences, but sometimes you can't avoid it. And thank you, Lisa, for your promising insights concerning the PA development in US. I think that's really a very good news. Mary, shall I share my screen?
Yes, go right ahead.
Okay, yeah, thank you. So my name is Peter Heistermann. I am the chair of the German University Association, physician assistant and program director at the Fliedner University in Düsseldorf with a bachelor and a master's degree in physician assistants. This is our wonderful campus. It is a very old one. And we have two main organizations in Germany concerning the PA. This is I call it my unit because I'm the founder. It is the University Association, and we have a professional body. This is the German Association for Physician Assistants, and we have another organization that is called EuroPAC, and they are not working very intense with the other organizations, and they do a lot of advocacy and so on. Nowadays in Germany, we have over 20 universities with PA programs spread all over Germany. The number has increased very much in the last years, and I'll show you the numbers. We have we have over 3,000 enrolled students in PA programs in Germany. And we have about 1,800 graduates which are working in Germany as a PA in the moment. And as you can see, the numbers are growing very fast. We have different study models, and the most common models are which need a training prerequisite, and we have another program model which we call primary qualifying, where you don't need a prerequisite as a health professional. So to come to the end, I should keep it short. Mary, you said 2 minutes. I hope I'm just in time.
You're doing great.
The factual situation in Germany today is, as I told you, more than 1,800 PAs are presently working in Germany. And up to now, they are predominantly working in surgical departments in hospitals, not in the outpatient sector. And what they do is what PAs do all over the world. They make assistance in history taking, physical examination, surgical assistant, treatment organization, and organization of documentation, and so on. Area of concern is the substitution of medical procedures, which we up to now strictly object to due to political reasons. But I think we are on a good way, and I think in the conclusion we can say that the PA has arrived in the German health system. And these are my contact details. If you want to contact the German PA, don't hesitate to call or mail me at any time.
Thank you so much for that, Peter. Thank you.
Mary, could I just ask Peter one question?
Yes, of course.
So it's very interesting, Peter, to see the numbers grow. Are you anticipating a continued growth pattern in the future?
Yes, we do. If you compare the number of the PAs to the number of inhabitants, for example, in the Netherlands or even in the US, I think we could reach a total number of 25,000 PAs in the next years before we reach saturation in the health market.
Thank you. Great job.
Thank you so much, Peter, for that update. And I know you mentioned, so we, just to update people who have been joining, we did our updates from AAPA, IPAE, and Germany, because Germany has to leave, so we had gone out of order.
Thank you very much.
Peter, I know you mentioned something about EuroPAC, and I see Dawn here. Dawn, we usually start with the 4 orgs. So Dawn, do you want to give us an NCCPA update? And I know you attended the EuroPAC conference. We have not heard from EuroPAC in quite some time, so love to hear any updates from your end for NCCPA. So thank you and welcome. We're excited to see you here.
Good morning. I'm sorry. I am in a meeting right now, so I can't really talk. I'm doing double duty.
Oh, so is Peter. So a few people.
So I wanted to just listen, and I'll put some notes in the chat if you don't mind.
Okay, no problem.
Okay, thank you very much. Yeah,
right.
It is. I only want to add the remark that I'm personally very concerned and very sad about the missing cooperation, and the University Association was not even invited to that meeting. So I think that adds a lot.
Yes, yes. We reached out, as well as PAs for Global Health reached out, IPAE also reached out. With no response. So quite interesting. So thank you so much for that update. Peter, Scott, any comments on your end?
Bye-bye.
Nope. Okay. All right. Let's move to our first country alphabetically, Colombe. Colombe's here from Burundi. We can't see your face, Colombe, but if you want to put the camera down a little bit.
Yeah.
Please tell us their updates about, there you are.
Yes, I am.
Please tell us updates from Burundi.
Thank you, Mary, for this time and for this meeting. For who are not recognizing me, I'm Colombe from Burundi, and we are having a program which is called Science and Techniques Paramedical, which means we are training clinical officers here, but they are called paramedics.
Colombe, could you speak up a little bit? Could you speak up a little louder?
Okay, I'm saying I'm Colombe from Burundi. I don't know if you are getting me now. Are you getting me now?
Yes, perfect now. Great, thank you.
Okay, thank you. I'm Colombe from Burundi, and we have a clinical officer program, but it's called paramedics, science and techniques paramedics. And then here the program is bachelor's program, which is bachelor's degree program, and we have almost 3,000 graduates from the program. But the regulatory body now is not established yet, but we think very soon to be established. And then about the program, we are doing harmonization with EAC countries, and we started the process of harmonization of the programs, but we still on the beginning of the harmonization, and I think the nomenclature would be also in the harmonization process. Yeah, that is it.
Thank you so much. Any questions for Colombe?
I wanted to ask Colombe, how many years have you been in the teaching program, and how many graduates do you have of your program?
The program in Burundi now have a 3 years degree, but this now the system of education in Burundi has changed to 3 years. It was 4 years before, now it's 3 years. And now we have approximately 3,000 graduates from the program. I don't know if you got me.
Yes, we got you. Perfect. Thank you so
Okay.
much, Colombe. Thank you for that update from Burundi. We'll move.
Thank you, Mary.
It's good to see you.
Thank you.
Thank you. We'll move to Canada next. Patrick Nelson. Thank you.
Good morning, everybody. Well, at least it's morning here. I'm Patrick, the Executive Director of our National PA Association here in Canada. We have had a pretty successful couple of years, whereas we used to have PAs in 5 provinces. We now have PAs working in 10 provinces in some shape or form. A few are just pilot projects. Despite that, our numbers are still growing pretty slowly. I was surprised to hear how many are in Germany now. But we're probably around 1,300 PAs working in the country. We used to have 3 programs across the country, and we now have 5. So I think the total number of students enrolled annually is just under 100. But we've got a couple of new programs on the way. One at U of Calgary, Dalhousie on the East Coast has a program now. And I would expect we'll see 2 or 3 more pop up in the next year and a half or so. And that's probably what's most important to you folks. There you go.
Thank you so much. Anybody have any questions for Patrick? Okay. All right, let's move to Patrick. Thank you for being here. Hopefully you can stay. Okay, Fitsum from Ethiopia. You want to give us a country update? I know you are in the UK right now, and Fitsum is going to be presenting about our loop model at one of the conferences in the UK shortly. So Fitsum, please do give us an update.
Okay. Hello. My name is Fitsum. I'm currently in UK, as Mary said, and my background is Ethiopian Public Health Officer, and my role was Executive Board Director for Ethiopia Emergency Surgical Officers. And in Ethiopia, PA education started in 1953 with the BSc education. The BSc education is named as Health Officer, and there is also a master track, and there is a regular and integrated curriculum track. And my background is this integrated emergency surgical officer, which is master's education. It takes 3 years for completion. And we have taken independent emergency surgical procedures for obstetrics and general surgery. And we have uploaded those curriculums on the loop curriculum, because this initiative was taken in 2009 for tackling maternal mortality and for improving surgical access, which I hope others, emerging countries can also use this curriculum for tackling shortage of human resource. And there is currently PhD curriculum for us, which we can join for PhD, which was established before 3 years. And PhD was a role of general public health. Previously, it was designed for integrated emergency surgery, but they make it one loop of general public health. So you can check these curriculums on loop. We have uploaded since 2022. We have started. Thanks to Mary and Scott. You can check my emails, and you can contact me. Currently, I am pursuing my leadership in international health leadership at University of Bradford at UK. Thank you. Nice to meet you all.
Thank you so much, Fitsum. Any questions for Fitsum? The maternal mortality has really improved since the creation of the emergency surgical officer. So
Yes,
very proud.
70% reduction. When we started the program, maternal mortality was in Ethiopia 767. Now it's around 267 per 1,000 labors. Yeah.
Amazing. Great job, Fitsum. Thank you so much.
Thank you.
I don't know, is Anthony here from Ghana? He told me he was joining, but there's some unknowns and another Scott Smalley.
Yeah, currently we have we have planned to start this program in Ghana for West Africans. Yeah, so we have started communication with Ethiopian educators. Our educators are actually, they are gynecologists and surgeons. So because they already started in Ethiopia before 15 years, why not in Ghana? Why not in, maternal mortality is majority of them are due to PPH. So it's possible to implement this. So we have been in some sort of communication, and the university bring this idea for the Senate, and we are waiting for their decision.
Okay, thank you so much, Fitsum. And then we'll move on to our next country. So thank you, Fitsum. And I know we have a lot of unknown numbers here. We're going to move to Ghana next. I know Fitsum gave us a little bit of an update of how Ethiopia is collaborating with Ghana. I know Ghana is also collaborating with Germany as well. Is Anthony here? Anthony? If not, we'll come back to him. Gomathi from India. I see that you're here from India. Do you want to give us the update on India, please? Oh, you're on mute.
Some of you know about the status of Indian PAs over here. There is an act which was passed in 2021, and a council is to be started. The council is going to club everyone together, that is all allied and health professionals together, and we'll be getting a new title, or we already have, because the act has been passed. We are officially physician associates now. There are over 100 PA programs in India across the country, and it is only an estimate. We still don't have a proper number, and we are working very hard to get everyone together and see what's really happening within the country. So the most popular program is a bachelor's degree, and there are efforts to start some postgraduate programs as well. So I think past 6 months we are now in a standstill because the elections are happening. So at the government level, no one is interested in anything else but the elections, the general elections. So we are waiting until June. So after that, something can progress. So that's all from India. If I can ask a question now to the guests who have presented so far, can I? Or
yes, please do. Please do.
Okay. I was just listening to a few of you all, and then I just wanted to ask one thing. Are there any other professionals which have who have overlapping roles or conflicting roles in their countries, and how do they deal with them? So we have a lot over here. For example, we have operation theater technologists who do almost 3/4 of the job what a surgical PA does. And when hospitals advertise for jobs, they say operation theater technologists / physician assistants. So that's how it goes. So I would like to know if someone else is also some other country that these challenges are there.
I think that's a great question, and I want to hold the answers to that questions just right now. But because I think there are a lot of conversations where this is happening in a lot of different countries. It's the whole task-bearing nature of things and being clear about the roles and the scope of practice. But I think that's a great question. We'll definitely come back to that. So thank you for that. And if anybody wants to put any answers in the chat, please feel free to do that too. Anthony, I think, Gomathi, thank you so much for that update. And any questions on what Gomathi presented? No? Okay, we'll move to our next country. We're going to move backwards a little bit here. I think, Anthony, have you joined from Ghana? as Scott Smalley? So I see. If so, you are on mute, because I see Association of Ghana. Anthony, is that you? I don't know. All right, we'll come back to Ghana. I definitely see Ghana here. I don't believe anybody is here from Ireland at the moment. Or Israel. Israel, Roy is still working with the PA program. There's still conversations. Dave Mittman is also helping out with the PA program there. There's currently obviously a war, and they have found that the PAs have been quite helpful actually in the emergency departments with everything seeing patients. Kenya, I know we have a few people from Kenya on. Austin, are you
there.
there?
I'm
Is that
there.
you? Is that you, Austin? Yes, please go ahead.
Yeah. That's me. That's
Okay. All right. Feel free to go ahead.
so. Thank you so much for giving me this platform. We are sorry, most of the Kenyans we are on the streets because we are doing our 30-day. Today's the 31st day nationwide strike for the clinical officers in the entire country. We are on an industrial action, so most of the clinical officers are not at work. And being that back here home in Kenya, I'm also a national official of the union. So most of the time we've been engaged and we've been very, very busy engaging the government. And we hope so that very soon the strike will be called off and we'll resume work. Most of the reasons why we are on strike is we are asking for a risk allowance, which is paying the doctors.
Uh-oh, Austin, you froze.
Some significant amount of money that take more risk than any other health professional, because they are the first people who are getting into contact with the patients. And then there is also the skill pushing can sign and put it into effect, where a clinical officer with a diploma moves to degree, moves to master's, and moves to PhD. So it is in paperwork, but it has not been officially signed by the principal secretary or the relevant office to that effect. So those are the main two reasons why we are on strike, and of course other things that are just internal, and also the payment of interns. In Kenya, the clinical officers undergo a mandatory internship for 1 year, where after that is when you get your license. So they reduce their pay from $1,000 to around $500 per month. That's a stipend. So those are the reasons why we are on the streets. But as I want to say about Kenya, I believe there are very many people from Kenya. I just want to stress the fact that we've had the East Africa Joint Regulation meeting, where, in East Africa, there is the East African Parliament, and there is also that collaboration that brings the East African countries together. I want to announce here that Somalia has joined the East African community, and we are told that Ethiopia might join the East African community very soon. So as the doctors had already done their part, it is very clear that all the doctors in East Africa can work in either of the countries where they will be given a license. So their training has been regulated, and they have one curriculum. They do their inspection to all those universities, and it has become very easy. So the Council of Ministers of the East African countries ordered that the same can also happen to nurses, clinical officers, laboratory technologies. Now, the clinical officers took that initiative under the leadership of the registrar of the Rwanda Allied Health Professions Council, and of course through GACOPA, where we had the first harmonization meeting in Kigali, Rwanda. That was around February. And of course, with the help of also IPAO and Loop, documents they have there, we came up with a committee or a team that comprised the registrars and the chair of the councils within those regions. And from there, we had to come up with a document, which is with us. And I can confidently say that the Council of Ministers have been meeting this week in Dar es Salaam, Tanzania. where the team drawn from the East African countries presented that document to the Council of Ministers, and it was approved. Now, what will happen after that is they will come up with a team that will now do the harmonization process to come up with a document. They inspect the universities and the colleges within East Africa so that they conform to one standard, so that you don't find someone in Burundi having the Bachelor of Clinical Medicine totally different with that one in Kenya. So we want that harmonization process has begun. And as I conclude, that is East Africa. And when I talk about East Africa, I also involve issues that are happening in Uganda and Kenya, which is more or less the same. Everything is on loop, and anybody can check and see the success stories that are happening in Kenya. They are even right now. We have even introduced PhD programs for clinical medicine. And finally, I just want to say that apart from that, on the issues of GACOPA, which is the Global Association of Clinical Officers and Physician Associates, where I head, we are having our conference in Botswana in August 26th to 29th, and I can say that the government of Botswana has endorsed that conference. It will take place at the DDT College of Medicine. I know the IPAO President Scott Smalley visited the DDT College of Medicine and has got a good working relationship with them. We just saying that we can also meet there and also engage. It will be a successful conference, and we expect a large number of clinical officers, PAs, and medical assistants to attend that conference. Otherwise, I will welcome. I see my vice president, who is also the GRAPAC president, is in. I think I will stop from there, but I'll be ready for questions thereafter. Thank you so much.
Okay, thank you so much. That was a lot of information, great information. Austin and team works tirelessly. Any questions for Austin? Okay, and we hope everybody is able. Oh, go ahead, Scott. I'm sorry.
Sorry, Mary. I just wanted to, Austin, congratulate you in the East African community on this reciprocity that you're forming. And you joined the call a bit late, but Lisa Gables was just announcing in the United States that there were 7 states who signed on to a very similar reciprocity called the PA Compact. And I think there's quite a bit that AAPA can share with East African PAs and clinical officers to learn from each other on that. So let's look forward to gathering in Gaborone for Botswana for the GACOPA conference and sharing more, and then coming to Lynchburg, Virginia for the IEPA conference. And we can continue this really good discussion of this reciprocity that's happening regionally and look how we continue this globally. Thank you.
I love it. Thank you so much, Scott. Great comments. And yes, Austin gave us a little bit of updates.
Thank you so much. Yes.
Thank you, Austin. Austin gave us a little updates of the Botswana doctor's assistant is named there. So, and how harmonization is occurring. So nobody is on the call from Botswana that I know of, but Anthony from Ghana, if you want to come on unmute and talk to us about the West African Association of PAs, as well as what's happening in Ghana. Good to see you. You're on mute. There you go.
Thank you very much, Mary. I hope you are doing well. I'm sorry I joined a bit late. I'm still at work, and so we've been talking. And thank you for the work you've been doing with the IPA and then the IPAO advocacy. And we are happy to have gotten here. A lot of things ongoing when it comes to Ghana. We've been able to trace our history back to 1923, and till now, it's more like last year was like a century since we started. But the profession was actually established as a profession in the 1960s, but our history dates back to 1923. And I think in our global publication, we have stated something like that there. We've done so well. We have a regulatory body, which is the Medical and Dental Council. The Ghana Medical and Dental Council regulates doctors, dentists, physician assistants, which are PAs, and then what now we call the certified registered anesthetists. Initially, they were called physician assistants anesthesia. Then they fought for a name change that they don't assist any doctor, and neither are they nurses too. So they don't want to be called nurse anesthetists. They don't want to be called physician assistants anesthesia or anesthetist. So they chose the name certified registered anesthetist. Currently, our educational system is at the bachelor's level in Ghana here. It's a 4-year bachelor's training. Then after you do internship for 1 year, and during the 1 year internship, you are given a provisional license where you are to work under supervision for 1 year in specified hospitals. After the 1 year, you are given permanent licensing to practice in Ghana. The law that regulates our practice here in Ghana actually permits foreign registration of recognized or accredited institutions. So if you are trained in Kenya, Botswana, US, Afghanistan, and you submit your document to the Medical and Dental Council, they will assess and allow you to sit for the state licensing exams. If you pass, you'll be given a certificate to practice in Ghana. And I think this thing should be done in other countries so that we can have these cross-border practices. In West Africa, we are trying to do that. So we've had challenges in Ghana here. The activism from the professional point has been very strong, very, very strong. At a point, they tried to introduce some scope of practice here. We have our job description by the Ghana Health Service. And in the Ghana Health Service job description, there is no provision for physician supervision. We've never had those things here in Ghana. What our job basically is to diagnose, is to treat, manage, rehabilitate, promote health, and preventive health as well. And we are mostly, distributed within the sub-district. So we don't have these supervision crosses here. But because of that activism, where we were fighting for much independence, for the doctor, for the government to employ more of us, better conditions of service, the physician community were threatened. And so they struck and struck. Most of our health systems have been headed by them. You go to the major heads in the hospital setting, the medical superintendents are mostly medical officers or medical doctors. The districts, the regional health, and even at the national level, at the Ministry of Health, they are all doctors there. And unfortunately, our teaching, our educational setting, most of them, the deans, the heads of departments, they are all doctors. And so at a point when they came at us during the law, tried to amend the law illegally so that they can put in supervision clauses. We fought it big time. We went to the National Labor Commission and stopped it. So this time, what they did was that they informed their counterparts that are actually running the PA training programs in the schools to withdraw from the schools. Now, when they withdrew from the schools, what happened was that the school couldn't meet the accreditation, professional accreditation requirements. And so some of the schools have been shut down. We had about 16 programs. I think it was more than 16, but there are 16 accredited programs. They have shut them down to about, we have about 3 programs now from 3 different schools, and then for PA medical, and those dental who are trained as physician assistant in dentistry, I think there are about 3 or so, or about 4 of them. Then we have the anesthesia, about 2 or 3 of them. And so because of these things happening, myself and my team within the West African region the West African Association of PAs decided to increase our advocacy and also our connections in salvaging the profession. So we looked at the entry, and we looked at the future. And most of the times, even in the UK, US, everywhere in Ghana, these medical officers or physician community, they boast about duration and length of training in the school. They will tell you that a physician did 4 years in the state and then did 5-year residency, did 3-year residency. You go to the United States, they boast about duration. And it is assumed that the longer you stay in school, the more you know. And medicine is complex. You are dealing with the human body. So we can't just decide here in Ghana, secondary student or senior high students, they train directly for 6 years. And then graduate entry, they go for 4 years. After the 4 years, they do housemanship for 2 years. And they can now be registered to practice. So the difference with PAs is that PAs train for 4 years. And then they do housemanship for 1 year. Okay. And so what we are looking for not just quality or advanced education, but also some way to bridge the curriculum. So before the war in Ukraine and before the COVID, I had sent a lot of applications and proposals to many institutions worldwide, to Malaysia, to United States, to Ukraine, to Kenya, we did Ethiopia, a lot of them, to see if we can have a postgraduate education that can bridge the gap in medical school, okay? And then we can contribute in content and also to produce educators, PA educators who can take over the schools so that we can protect our future. And Germany as well. So we've succeeded. Like I have told you, we have enrolled people in Master of Medicine, and this is a physician level training. So we were able to have a lot of proposal from Ukraine, VN Karazin, Kharkiv National University. Mostly they will not even allow you to enter a 3rd year or whatever you have. They want you to start from a first year, do 6 years. But because we went in with a special proposal, we were interested in the program. And so we have enrolled people in Master of Medicine. In fact, they will come out as doctors, but these are people who we are training with our philosophy and our culture of training to come with the requirement to save our program in the West African sub-region. So you have people, as in the United States, you have the Doctor of Medical Science. We decided to take the Master of Medicine. That's one. We have also petitioned some schools in the United States. It's not easy to have access into the Doctor of Medical Science degree program, but we succeeded with that. And then Germany too, we have had partnership there with education where we can advance our people. Our people can have cross bilateral cooperative agreement between Ghana and Germany, and maybe for Liberia and then Germany. That is what we are trying to do, so that if we cannot remove these hurdles of cross-cultural and cross-border practices, at least we can start by bilateral agreement between countries, so that one country practitioner can assess the curriculum, like what you are doing. We can assess and have that intercultural, exchange and then cross-border practice and training.
And that's so important. And so I want to make sure everybody has time to speak and present. Anthony, it's fantastic work that you're doing. And I don't know if anybody has questions for Anthony. We could also put those in the chat for the sake of time. But Anthony's been working tirelessly with Galcopa, with West African PAs. and really and he's gotten support from the Ukraine and organizations as well as Germany, and it's pretty phenomenal. So keep up the amazing work, and anybody have questions? Thank you, Anthony, so much. You can tell, like, I talked to Anthony the other day, probably for like 2 hours. So Anthony has so much to share. It's phenomenal. So thank you so much, Anthony. We don't have anybody from Kosovo. I'm just going in alphabetical order right now. Update on Bulgaria, because I skipped over Bulgaria. So Bulgaria PAs are happening. You could see the article in JAPA. So good things are happening there. Laos PAs are still existing as well there. Myanmar, they're still training there. There is a war situation going on there, and the PAs are actually helping quite a bit there. And I have knowledge from some of the people that I know that are working on the ground there with some of the special forces teams. And they are local, they're locally trained there. So I want to go ahead and introduce Jerry Coley, who's here from Liberia. Jerry, do you have any updates for us on Liberia? Jerry, are you there? You're on mute. There you go.
Oh, yes, Mary, thank you so much. And good afternoon to everyone from Liberia. So I think I listened to Austin Kinley, and I'm in sympathy with what is happening in Kenya. And I'm so happy to hear the sort of collaborative aspect in ensuring that activities are coordinated in the East African belt that give leverage to PAs from one country to another and other medical practitioners that will have opportunity to practice in other countries. The situation of Ghana is no different from Liberia, as Anthony just explained. It's no different. In fact, for Liberia, we are still far behind the belt. And I'm hoping that one of these days we can leverage on the experience of Ghana and other countries to see how we can navigate ourselves from this nightmare. Like Anthony said, almost all of our PA training institutions are headed by medical doctors. They make the higher decision, and for any reason, and most of the major courses are taught by medical doctors. Higher education accredited institutions will demand that some major courses are taught by medical doctors, and for any reason, maybe PAs insist that, oh no, we don't want this, and then they say, okay, then we have to shut down the institution. But it's a long story. It's a long story, and it's something that we need to think about globally as PAs analog across the country or across the world to see how we can be able to address some of these major challenges that are cross-cutting. In Liberia, basically, we have roughly 5 PA training programs, and there are a lot of institutions that are also now applying to the board for accreditation to train PAs. The highest academic credential for PA now is bachelor, and it is just one training institution that is providing that for now. We even don't have any such specialty in any other programs, like a PA becoming an ENT specialist, a PA becoming an let's say ophthalmology specialist. We are finding it difficult. Everyone is just more or less a general practitioner, and medical doctors are taking so many advantages on PAs in this country. But it is my hope as Kenya, Ghana, and other Western countries are picking up, one of these days Liberia will follow suit, and we all will find ourselves somewhere where our profession will go to the peak that we envisage. Thank you so much, and we are part of the process as far as we are concerned.
Terry, you're doing a great job and what you're doing in Liberia. And we know, I mean, the PAs in Liberia were taking care of Ebola. So they are key parts of the healthcare system and team. So thank you so much. Any questions? I know we're running short on time. We have about 35 more minutes of our meeting, but I just want to be caught. And so, Joseph, go ahead. Question?
Oh, yeah. Thank you very much. I haven't attended these meetings in quite some time, but glad to be here. So my name is Musonda Joseph. Kamfwa. I'm the Secretary General for the Clinical Officers Association of Zambia, which is a PA equivalent to like in other countries, although we have a bit of a different, or rather a more diverse profession, I think, than majority of the countries that I've had here. We have about 9 divisions of what you regard as physician associate assistant. Pertaining to regulatory matters, we don't have really much of a problem that that hinders us to what we can do and what we cannot do. So we have the clinical officer who's a diploma holder. We have 2 divisions under diploma. Then we have the advanced diplomas that are 4 in divisions. There are 4 of them. Then a bachelor's degree holders. There are 4 divisions again, where we have the medical licentiates, then the anesthetists, and we have the ophthalmic. We call them the ophthalmic officers, but government is going to be employing them as ophthalmic surgeons, but they are at mid-level. And we have another division, which is the mental health and psychiatry officers. These are bachelor's orders, but we do have a training at master's level, a Master of Science in Clinical Ophthalmology that has also been introduced. But we are also pushing that the other divisions also introduced. We only practice up to a certain level. For example, in tertiary hospitals, government decided that they remove most of the clinicians from there, basing on the way that our healthcare system has been structured, and also to avoid these issues that have to do with doctors having this part and then also us having the other side. So we were taking most of us to primary healthcare and secondary healthcare levels. So at primary healthcare level, we have what we call the medical licentiates, where they perform most of the procedures there. It be surgeries. They do work at the same time with the doctors on the same. They basically do almost just the same thing. There's nothing like, no, this one supervises the other and the other one supervises the other. No. But what differentiates us is I think the salary part, which is almost currently it's almost 3 times what the doctors get and what the medical licentiate would get. But we are working on that. Government has responded positively. So we may change that status quo, I think, as early as next week. Right now, I'm at Ministry of Health. I came to see the HR, the Human Resources Department, whom we're working with to just ensure that we normalize some of these salary issues. But that is what we have been trying to work around. But at the same time, I must report that in Zambia, unlike other countries, the anesthesia, or rather anesthetic services, are 98% provided by ourselves. We don't have the profession which you call nurse anesthetist. We just have the clinical anesthetist. So anyone who's trained in anesthesia, by law here, they are supposed to be a physician associate assistant equivalent. So about 98% are mainly provided by ourselves. I think we just have at country level about 23 anesthesiologists, and that is not enough. So we find that at every level, without us, it would be detrimental for the sector. So that is what we've been doing. Then also the eye services, which is the ophthalmic officers. Yeah. If not all the services, again, at every level, we are the ones that are responsible for that provision, and we don't have a lot of doctors that are trained in that. I think for that, they are less than 10, as well as the ENT, which is the ear, nose, and throat specialists. Again, those are more, they are clinical officers, and at country level for the doctors, I think we just have 4 of those. So majority of those services are provided by ourselves. Hence, the limitations in terms of what we can do is not really there. What we did fight for as a profession and as an association is to ensure that we sit in decision-making bodies. For example, I sit in the Health Professions Council board, specifically a committee that looks into the licensing needs and approving of who gets to be licensed as a doctor and so forth, and anything that has to do with the regulation around that. I sit in that, and we're the ones that determine. So it's easier to really advise the minister to say, no, take this route, take that.
It's really good that you're in that space.
Yeah. And my president himself, he sits in the main board, where when we do all these issues, we submit to them, then they do the ratification. So it is quite easy. We don't have much of these challenges. The only challenge we had was to put ourselves together, because in the past, despite us growing in numbers, we didn't have an organization that was able to speak for the profession. But when we came on board, the sector did respond positively, and that is something that we have worked on. We don't do, of course, what Austin and the team are doing in Kenya, where they go on strike, because if we are to strike, I don't think our healthcare system would survive, because nearly at all levels where majority of the patients access the services, we are the ones who are there. There are no doctors there, so it would basically collapse the system. So whenever we have any grievance, what usually happens is, like the other year, when we had a grievance, the president himself of the nation had to go to us, and we went and met him at State House. And so we try to resolve issues by utilizing those means. So basically, that's what we're doing. Yes, we are trying to also see what you yourselves are doing for master's programs.
Perfect.
Yes, we'll try to see what we can adopt and see what we can do. I'm just not sure on the regulatory, the nomenclature that you're trying to utilize worldwide, if it can be adopted.
And we'll talk about that. We'll talk about that in a few minutes. So I want to make sure we have a time for everybody to present, so we can come back to that. And I know Gumathi's question as well. So thank you so much, Joseph. Thank you. Thank you. I don't think Solomon or anyone is here from Malawi, correct? No, I don't. I know there's still some unknown names here. And
we can have Lumbani give a bit of an update from Malawi.
Lumbani, do you want to give an update on Malawi? I know we were with Solomon in Malaysia, and Malaysia is going to come up next. So Lumbani, how about we give Malawi update when we give the South Africa? And I know it's late for Norris. Norris, do you want to tell us about Malaysia? We had a wonderful conference at the Galcopa conference there. Good to see you, Norris.
Yeah, likewise. Hello, Mary. Hi, everyone. I'm Norris from Malaysia. Well, just a bit of background. So we were in Malaysia, was Malaya then, since 1786. So we have been in Malaysia for the past 238 years. So we just celebrated our National Medical Assistant Day, which falls every 10th of March every year. So currently we have about 35,000 registered practitioners here in Malaysia, and we are growing strong. We have councils working together with the association and the union. And of course, we have an act, which is Act 180 in 1977. So we have an act governing our practice. So latest update is that, in fact, it's a good news. So recently, Ministry of Health of Malaysia has actually put a stand that we need to have a clear job description between the nurses and the medical assistants, or we are known as assistant medical officer as well. So because those days we are a bit, a bit what I call, we don't have a clear job description between the nurses and the medical assistant. And a lot of times perceptions will say that MAs are also nurses as well. So, but this year, the Ministry of Health has done a good job by putting medical assistants back to where it's supposed to be. So the nurses are, to be placed in the wards, the medical surgical ward. So that's where they are doing for nursing part, and medical assistant work in a specialist clinic. So that's the right move. And currently we are in the midst of reviewing our job description, which we have last reviewed since 1986. So we hope gonna come up with a review job description by end of this year. And also we're gonna come up with a new program standards because we are currently towards by 2030 to have at least 75% of the medical assistants to be to have a degree program, to be a graduate degree. So we are moving towards that. hopefully by 2030, we have 75%. So with that, we need to have a strong program standards so that universities or colleges that offers undergraduate programs will able to provide a standardized education in a degree level. So currently we have 2 universities running a degree program. We have about 6 government sponsored colleges running a diploma program. And of course, the rest, we have 12 private universities and colleges offering medical assistant program, because currently the ratio for medical assistant to our population ratio is about 1 medical assistant to 2,500 population. So that is shows that we need more medical assistant, as what mentioned by our Deputy Ministry of Health, that we need at least about 35,000 more medical assistant by 2025. So it's a good news for us that so we need to churn out more quality medical assistant, but we are focusing to produce more degree graduates among medical assistant. And of course, we hope to launch a master's program by end of this year, and possibly by next year, probably a PhD program. So you can see a continuation of practice and training for medical assistant from a diploma level, undergraduate and postgraduate level. That's all, Mary. Back to you.
Thank you. That was wonderful. And Norris, you also run an online MA program too.
Yes, exactly like what you're doing, Mary.
Yes. So there are online programs elsewhere as well. So fantastic updates. We had an amazing conference there. We got to go visit and meet a lot of the medical assistants, which was absolutely amazing. We got to see what type of work they do and all of that when we were in Malaysia. So that was really, really cool. Moving on to our next is Netherlands. Netherlands is not able to make it, but they sent me their update that there is no new news. They said there will be no title change. If we want to change the name, we have to come up with a good Dutch title name. So we couldn't come up with one. So we will stay with physician assistants. So that was the update from the Netherlands that we have. New Zealand is still moving forward. I had meetings with them a few months ago with PAs. Papua New Guinea, we know that they're existing there. Is anyone here from Rwanda? I don't believe I've seen anybody. Scott, stop me if so. Saudi Arabia, we've had several meetings, myself personally, with their Ministry of Health about potentially starting up another program there. Previously, it had only been with the military. There is no update from the ministers at this moment. I don't believe anybody is here from Sierra Leone. Nope. Oops, I passed P. Puerto Rico. Laura, sorry. Go ahead.
No worries, we're little. I have just a couple slides to keep you entertained if you want.
Yes, hold on. I'll make you co-host and go right ahead.
Okay, awesome. Since I know it's either early or late or something for everybody, in case that makes it more exciting. Well, thank you so much. My name is Lara Juarez, and I am the current president of the chapter for PAs in Puerto Rico. And now that I made such a deal about it, I can't get it to work, but here we go. You'll get the point. Okay, so just really quickly, just a couple things. This is actually a picture from a hospital that's near my house, and it says that for the moment there is no doctor, and they closed the emergency room, which is kind of what our snapshot is right now about Puerto Rico. So we've got 3.2 million people, but less than 10,000 physicians. And of course, the projected numbers are not looking very good, but we have kind of a unique situation because even though we are not a United States state, we do have some of the same privileges as the United States. And so the Puerto Rico chapter is taking it very seriously to make sure that since people in Puerto Rico can go back and forth between the United States, that we are not confusing the standards from the US with what a PA is. So that's our main focus right now. This is just really briefly our history. There have been 1 or 2 PAs on and off the island, whether they're at the in our federal system, so at the VA or the prison, for many years. But 2017 was our big year when we actually got a law that was passed. It was a little tricky, but we at least have something on the books. And then the first PAs that were actually able to get the license were in 2021. So that's kind of our big thing. Our problem right now is that our law Ley 71 uses this term medical asistente instead of using the term that the AAPA, NCCPAEA, PAs for Latino Health have endorsed, which is asociado médico. And at first we thought, no problem, that's just a miscommunication with the translation. But it turns out that was not a miscommunication. That this was part of the purpose was to create a profession with like an umbrella term that would include not just PAs, but also individuals who had done some of their medical school training and wanted to be able to try to practice in the States, and so could obtain this license to be called a PA. So here's our funny, we're trying to make people think it's funny and remember that a medical asistente from Puerto Rico is not the same as an asociado médico, and that our jobs and duties are also different. So here's our last one about our current status. So we talked about the title and the two different names. That's what we're working on legally right now. For the education, you can either have some of your medical degree or a master's degree as a PA right now in the law. So this is our other problem that we're facing. The scope of our practice is crazy. It's all across everything. So you will find some people that are only allowed to take a blood pressure, like assisting in the United States. And some people are seeing their own patients and prescribing, even though the law doesn't really allow it right now. So again, our goal for the Puerto Rico chapter of PAs is that we'll be able to be separate and diagnose, treat, and prescribe, since that's what PAs are trained to do. And our numbers, right now that we know of, there are 3 certified PAs that have gone to PA school and taken the NCCPA exam that have a Puerto Rico license, and there's about 1,500 medico asistentes. So here's all of our social media. We would love to have you find us and follow us. We have a little petition for our resident commissioner to recognize the profession correctly. So you can sign that and find us on all of the social media.
Okay, thank you so much. Any questions or comments? Okay. Hey, all right. Thank you for that update, Laura. And Scotland still has, as I had skipped ahead, Scotland still has PAs. Sierra Leone, I don't believe anyone is on from Sierra Leone. South Africa, Scott, do you want to give us an update? I know Lumbani left.
Yes, thank you. Scott Smalley, a physician assistant trained in the United States, and now the name change, a physician associate. But I've been in South Africa for 15 years, and I've been educating at the University of Witwatersrand, which is one of 3 programs that is running the clinical associate program, and we call it a Bachelor of Clinical Medical Practice, a 3-year degree, which matches other 3-year degrees in the country. And then we do offer a 4th year, which focuses on emergency medicine. And our students graduate and they can register with the Health Professions Council of South Africa, and they work alongside the doctors and nurses in the clinical spaces. Right now, the government support has been waning for our profession, and there's much more focus on doctors of late. So we're really trying hard within our professional association to strengthen it up, which is the Professional Association of Clinical Associates of South Africa, or PACASA. And we've also formed a consortium, Clinical Associate National Consortium, where we're trying to bring together our professional association. We have a union that's trying to get started. We have an academic team that's working, and we have different clinical associates representing the different spaces of private practice and public practice and NGO space and research. So we're really trying to form a strong voice, much like what Laura is saying with their association, to really influence the government and show the value add that clinical associates can have. And we recently did have a meeting with the National Department of Health in November, which was really good. So putting our footprint down, and we're scheduled to have another meeting coming up shortly. We also had to go the court route with the national government, and the public protector, which is kind of like the U.S. Attorney General, is holding the National Department to task we're not implementing several recommendations that were put forward by a government-sponsored national task team on clinical associates. So we're also hoping that this court route has some effects right now. South Africa is really in desperate need of healthcare practitioners, many places in Africa, and so clinical associates do provide that really excellent patient coverage. We do work under supervision of doctor, and we are legally not allowed yet to prescribe, although it is in our curriculum. So we face similar challenges to other countries, and South Africa being part of GACOPA and being part of IPAE and other places has really helped us, to get ourselves more recognized and known. We have right now 1,758 graduates, and we have the 3 universities that train about 250 students throughout the 3-year program. Thanks, Mary.
Thank you so much, Scott. Awesome. Okay. All right. Moving along in our countries, Somaliland, we heard from Austin an update. I spoke to Khaled the other day. They're doing well. South Sudan, I have no updates there. Switzerland, Anita and Sonia both send their regards. Is anyone here from Tanzania? I don't believe so. Uganda, I know Annette is here. And I think Bruno too. Annette, do you want to give us an update on Uganda? Annette, hello.
Hello. Hello,
Hi.
are you getting me?
Yes, we hear you. Fine, thank you.
Yes, one things from Uganda. I'm Namugosa Annette Kara. I'm a senior medical clinical officer, and I represent clinical officer on the advisory board of Allied Health Professional Council. And my position at health facility, I head a health center 3. In Uganda, we are not very far from Kenya, except that clinical medicine program started in 1918 as medical assistant by Dr. Albert Cook. And then in 1929, the program was adopted by Uganda. Currently, we have around 27 training institutions training in clinical medicine, and among them we have only one university, which is private. And then we have 2 programs, that is a diploma in clinical medicine and bachelor's in clinical medicine. And we have higher diploma in clinical medicine. Those are people who do it under psychiatric, clinical medicine, ENT, anesthesia, and ophthalmology. And we are having a lot of hope in this East African community inter-regulatory body harmonization program that a lot will come on our side positively. For example, we still have a challenge like clinical officers who have done bachelor's in clinical medicine, and they are not yet taken up to work under government. And there's always a big discussion about the scheme of service and scope of practice, which has not yet been released out. When it comes to curriculum, our curriculum with the training institution of Kenya are more or less the same. And also, when it comes to the nature of work, we are the first people to interface with the clients and the patients. And also, we cover about 80% of the population of Uganda, because we work in rural and peri-urban centers. I don't want to talk a lot because most of the things have been said under Kenya. Thank you very much.
Thank you so much, Annette. And I know Bruno's here too. Bruno, anything on your end? All right. Thank you so much. Thank you. I know we have already spoken about, hold on, did I skip? So Uganda, UK, Kate and is in a GMC meeting, General Medical Council meeting right now. She sent me the update that regulation is now agreed upon. GMC consulting on the rules and regulations and will formally open up for registration in December. And the rest is largely as it was. There are 5,000 PAs practicing in country and 37 schools currently in the UK. So that is the update from the UK. We had our update from Zambia earlier, and then Alice, I think, had to leave from Zimbabwe, unfortunately, but put in the chat from Zimbabwe, we are still fighting for recognition. We are currently under the Nurses Council of Zimbabwe, since one has to be trained as a general nurse for 3 years, then a midwife, and then a clinical officer for 2 years. So Nurses Council considers us as advanced nurses and is not willing to let us go. The major challenge is we only 71 according to the current database, and training has been stopped. So thank you, and she had to attend to other matters. So that is it for our updates. Is there any country that I missed here? I know there's still somebody named unknown number 4 there that I don't know who that is. And we also had some of the questions before to address, are there other professions that are similar? I think we've talked a lot about that. Did anybody have any questions or comments to address the comments that Gomathi and Anthony had asked earlier? Or any other final comments before we end? Scott, go ahead, Scott.
So I just think it's really nice that we're having this annual IPAO meeting, and I really appreciate AAPA and Lisa, your work for helping to continue this and for supporting Mary as the ambassador. She's done tremendous work, for all these countries and the different organizations. And I think it's, these questions that Gomathi and others raise, we've really been able to address a lot of them together. And we're really learning from each other about how to solve some of these problems with different countries. Some of us are in the different places. We've done it before, so we share with others. It's new for them. And I think these conferences are starting to really take hold. The COPA conference coming up. Many of us are going to attend in Gaborone and Botswana. And of course, then the IPAA conference in Lynchburg, Virginia. Many of us will be there, and we'll continue these conversations and development. So I guess I want to thank this forum for the opportunity. Thank you, Mary.
Thank you. Thank you. And IAPAE hosted a lovely conference last year in India. So we are continuing this collaboration. And it was the GALCOPO conference was amazing, with I think over 200 clinical officers showing up from Africa, which was amazing to it. I want to say thank you. And Lisa, go ahead.
Yeah, I was just going to say, Scott, to echo your comments, thank you, everyone. This has been extraordinarily informative. And as always, I know we are struggling around the world to be recognized as who we are, to be able to do our jobs to the fullest extent of our training and education. And we certainly appreciate all your efforts in letting us know what's going on. And Mary, thank you so much, as always, for putting this together and bringing everyone so we can hear what's going on. So I appreciate everyone's time today.
Yes, thank you so much, Lisa. Thank you, Scott. Thank you, everyone here. There were some countries that weren't mentioned, but we're still going strong and continuing to work together, and we're stronger together. So thank you all. I will send out this recording. If there's any other updates, please do feel free to place it on the chat or email me, and I can get those out to everybody. Thank you so much for all of your efforts and your time. Have a wonderful afternoon. And look at this, we're ending 8 minutes early. That's unheard of. Have a wonderful day. Thank you so much.
Thanks, everyone.